We are going to have 2 presentations today, so 2 lectures. First part, I'm going to focus more on food-responsive chronic enteropathies. And I'm going to give you a short overview about that. And then later, my colleague Eva, she's going to continue with a bit more challenging cases and diagnostics. So keep your Zoom open for some time. I think it's going to be interesting, so we can start. So just short introduction. So I'm Diana Brozic, and I'm working as associate professor at University of Zagreb, so veterinary faculty. I'm also ECVCN resident, fully trained, and hopefully soon I'm going to take the exam. And yeah, this is kind of my focus of research nowadays, and also focus of practical work. So we see quite a lot of patients with chronic enteropathies. So just to start with explanation, what is exactly microbiota and generally gut. So in our gastrointestinal system or gastrointestinal system of our pets, we can see and we can find quite a lot of different organisms living there. So it is a homeostatic environment where there is a lot of bacteria, even some viruses, protozoas, and they have all their purposes. So when everything is in good order, so when animal is healthy and its gut is healthy, then normally what takes place in a healthy gut is a fermentation process. And here depicted, we can see that it says the words short-chain fatty acids, so this is for short. So after fermentation of the fiber, we would see the production of short-chain fatty acids, but not just those molecules. There is also secondary bile acids and many other active molecules that are a result of fermentation. They can have nutritional properties. So for example, short-chain fatty acid, especially the butyric one, would serve as a nutrient for enterocytes. And also they would serve as signaling molecules and immunomodulators. So their role is quite abundant. So this tells you then when things go wrong, there is a lot of consequences that would take place. And something that it is believed to be the disruptor of this equilibrium of gastrointestinal system is a interplay between gut microbiota, so dysbiosis that happens, and also disrupted immune response from the immune system that exists in gut, and also some genetic predisposition. And we also then see a lot of problems in terms of that gut being really reactive and reacting to nutrients in terms of intolerances and allergies. But also we see a change in that microbiome. So the healthy microbiome would be partially replaced by a lot of pathogens that are then more abundant and then would cause a lot of damage. And we are going to discuss that a bit further on. So this negative impact on gut health could be through various reasons. One of them, maybe the main ones, would be, of course, pathogens, especially viral infections, bacterial severe infections, and parasitic infections. And we know, especially from human studies, but it is something that it is now a research also in veterinary medicine, then that the younger the animal, the more severe the problem is going to be. So especially with really disruptive viral infections, like, for example, parvovirosis, it would when it happens, it causes a lot of damage. We know it's life-threatening disease, but also later in life, we can see a lot of chronic problems in those dogs. Also, the same applies to severe parasitic infections quite early in life, etc. Other thing that it is quite a problematic and would lead to this disruption of this homeostasis in gut is irrational use of antibiotics, and that is something that Eva is going to also discuss much more in detail. Just to put it out there, sometimes we need to use it, of course, but we know that it does damage, and it causes dysbiosis, and sometimes that dysbiosis lasts for quite a long time and can turn into chronic problem. And then there is a lot of stressors that can be problematic. And here maybe the genetic predisposition that plays quite a big of a role would be also the predisposition for those stressors to cause harm. For example, even just the changing of the environment, driving your dog in a car would sometimes cause diarrhea, stress diarrhea. Also the heat. So in that time period, a lot of those dogs that are really prone to stress and to stress response would have their condition worsen. So they would lose appetite or get diarrhea or stuff like that. So it's quite a few factors that we have there. And yeah, so as I already said, we would see a change in composition of a microbiome as a result, then increased permeability of the mucosa of the gastrointestinal system. That is also a quite important one, because as you see in this picture, for example, there is a wall of enterocytes on every villi. There is also a mucus layer lying on it, and then we have commensal gut bacteria lying on it in terms that they are fermenting, producing those nutrients, and basically feeding the gut wall and protecting it in the same time. But then when this barrier is disrupted, then the pathogens would bind to those enterocytes, and then they would excrete their toxins and harm the gut barrier. So this would also lead to permanent damage if those predisposed factors are there. And then something that we also see is intensification of inflammatory response. So we see that inflammatory response is much more pronounced. So then it would manifest itself in different animals, especially through, for example, intolerances to nutrients and even real allergies, so that immune system would react to a nutrient or a protein. And then, yeah, if all things kind of intertwine, we have a quite unfortunate event that the dog could end up with chronic enteropathy, even though we don't know what kind of flips it and what causes in the end, what is the major factor from those that I kind of evaluated now with you, but we know that all of those factors would play important role. So when we are saying the term chronic enteropathy, that term is used to describe persistent and recurring digestive signs that are in their nature chronic, so would last for longer than 3 weeks. And we can see quite a variability of different symptoms. So vomiting, diarrhea, abdominal discomfort, and various combinations of them when it comes to symptoms on the level of gastrointestinal symptom. And also we can see weight loss, but sometimes we don't have to see it, especially if the problem is just in the area of large intestine. So for example, colitis, then animal can even be obese or overweight because normally with colitis, we don't have that pronounced effect on absorption of nutrients, but in small gastrointestinal system chronic enteropathy, we would see quite a severe weight loss that is quite hard to correct. And yeah, when it comes to pathogenesis, as I said, it's a combination of various things. So we have their dietary intolerances, as I said, can be also allergy, then abnormal immune system and their reaction. Then we see imbalance of gut microbiota and genetic predisposition, and of course, environmental and, as I said, genetic factors that would kind of lead to it. How do we categorize it? So this is something that is ongoing thing. So we see every few years a different categorization, even though this one stayed a few years longer than maybe some previous categorizations. So we would have the categorization based on responsiveness to treatment. So my focus on this presentation would be this first line, so food responsive enteropathies. So those would be the ones that respond positively to the change of diet. And then the second one that I hit a bit, we would call previously antibiotic responsive enteropathies. And those ones are nowadays quite heavily criticized, not just nowadays, but a few years back, since we know about the dysbiosis and the effect that it has on the gut. So now maybe better term to use is microbiota-related modulation responsive enteropathy. So it's a bit like a long title, but that title would kind of refer to other modalities that we can use instead of antibiotic therapy that can serve much better than antibiotic did, and that are much less invasive. Then we would have another level that is a bit more severe presentation, where we need to use immunosuppressants. So the dogs that would respond to that therapy, they would be in a group of immunosuppressant responsive enteropathies. And then the final one, where we have a lot of problems in managing, and we see poor response to everything that we do, that I mentioned before, would be in a group of non-responsive enteropathies. And then protein losing enteropathy is also something that Eva is going to get much more into detail, is a group that is kind of outside of all of this. So we would use the same modalities, the same approach, but then those patients are a bit harder to handle. And at the beginning, normally they would fall sometimes just in this food responsive category, but oftentimes we see a deterioration of those patients, and we would need much sooner to use immunosuppressants. So you see this kind of triangle. So the first triangle would have this quite strict division. And in second triangle, it was published this paper where they announced this new terminology last year. We see kind of that the food responsive enteropathies and this microbiota related modulation responsive enteropathies would kind of merge together, because we don't see any problem with using maybe those modalities much earlier on when we are starting with diet. And then a bit less patients in immunosuppressant responsive and in non-responsive. So normally in this first group of food, so I crossed this antibiotic responsive. So in this first group of food responsive enteropathies, we have quite a high prevalence of our patients. There is a variety of information, so it's quite a range depending on the study. So normally it's above 50%, but we can even say it's closer to 70%. And for some group of patients, it can also be higher than that. With food responsive enteropathies, normally we see it, we can see it at any time point in a dog's life, but normally the younger the dog, the more likely it is that it's food responsive. And oftentimes we see in this presentation a bit milder clinical signs. And predominantly, we would see the presentation in large intestine, but it can be also mixed, and sometimes even the small intestine presentation can react good to dietary therapy, but it's much lower incidence, so to speak. So more likely it is when you have large intestine presentation that it is going to be food responsive. But yeah, we see a lot of different combinations. And if you have a food responsive enteropathy dog, then you are quite in good luck, because it is known through studies that if they show a responsiveness to this treatment, that it's quite likely that they are going to have quite fast clinical improvement and quite a good long-term response. So normally we would kind of guess already that a more younger dog with mild clinical signs and more large intestine presentation, has a higher chance to have food responsive enteropathy, and then a more older dog with more presentation that is present on small intestine level is more likely to be a bit more challenging patient to handle. But yeah, we see quite a variety of combinations, so this is not strictly like that, but it's more likely to be like that. And then how would we handle a case like this? So super quickly, for this part of just the screening that we do at initial visit, because Eva is going to go much deeper into that part. So I'm just going to quickly mention what we are doing, just not to skip it. But yeah, we would normally take dietary history and general anamnesis. Then we would do a scoring with chronic enteropathy score that I'm going to show you later, and of course do the clinical examination. You would check the blood. Of course, it is good to check also electrolytes and do urine analysis. And then never skip the parasitology examination of feces. And when doing gastrointestinal panel, something that is also a golden standard that Eva is going to explain further on is to do a cobalamin and folate, check the pancreas, of course, and also exclude Addison disease. And then with imaging, of course, ultrasound and radiographs. And then you have a clean slate. If everything is fine, you can then continue with elimination trial. And this paper is quite a nice one from 2022, because it's showing two elimination trials that you should do. Nowadays, even some authors would suggest that it's reasonable to do even 3 elimination diet trials. You have to do them quite intentionally. You have to choose your diet individually based on your patient. But normally there is a few modalities that you can choose from, and it is something that should be done. Yeah, if the first try doesn't work, then you have something else also to try. Regarding with the duration of elimination trial, something that it is also reasonable to do is that you don't need to wait, as for example with dermatology patients, for a full 2 months to conclude your call, is this diet working or not. With gastrointestinal patients, you would see the results much sooner, normally in a few days. If the diet works fine, you would have a good response or a better response, and then you can kind of seal your elimination diet protocol with a single diet at 2 weeks. That would be quite enough to see marked improvement if the improvement is going to happen. If there is no response, and you really feel that this dog would be food responsive enteropathy, you can choose another dietary modality and repeat the same steps. And we are going to discuss that further. So when it comes to clinical scoring system, this is something that is really useful to have alongside the follow-up of your patient, because it gives you quite a clear information about the improvement of the clinical signs. And also it's really useful for the owners because it gives them also kind of the they can do it by themselves, so you can explain how, especially for the things that they can evaluate by themselves. But they have more understanding if their dog is actually getting better, because oftentimes we would see that, yeah, patient improved markedly, but in their eyes it's still maybe the stool is a bit softer, but we see a decrease in the frequency of defecation or some other things. So it's good to have a number. So normally this clinical scoring system that has a lot of C's in its name, it would grade few things. So attitude, appetite, vomiting, stool consistency, stool frequency, weight loss, then albumin levels, ascites and peripheral edema, and pruritus. So those are the clinical points that you're going to evaluate and give the scoring. So normal would be 0 and 3 would be the more severe presentation. So the higher the score, the worse your patient is. So normally we would grade like 0 to 3 would be a clinical insignificant disease. So when you have a remission, you want to see your patient around that number or close to 0 as possible, but not above 3. And then 4 to 5 would be a mild chronic enteropathy, and then 6 to 8 moderate, and above 9 severe presentation. And something that is also quite a good thing to explain to the owner, because not to receive too many pictures of feces in your email, would be to kind of teach them how to score a feces. So this is something that they can do by themselves. And you have quite a precise scoring. So there are few scales on the developed, but this one I like quite a lot because it has 7 points. It's quite detailed. It's not too detailed again. So the 2 would be the ideal fecal score, and then everything above that would be a bit problematic, but then we have a grade, so you can test or you can evaluate the improvement of the patient. And of course, something that is also important is the presence of mucus or blood that you're going to test with this stool frequency. So the presence of either, it's going to also tell you that the patient is still not stabilized. So you still need to work on some things to improve that fact. So let's look at this study that I think is quite nice. And it shows really what changes when it comes to remission that is caused by diet. So when we have a food responsive enteropathies and you have your dog in remission state, so they basically evaluated what changes, what is different from the starting point to the dogs that are now being controlled and are in remission. So something that is, so just to start from the beginning, so this study evaluated 29 dogs, and they did evaluation after 14 days of when they introduced this new diet. And they had 69% of remission. So 69% of the dogs would be in this food responsive group. And they saw in those dogs that the microbiome changed markedly. So they found that there was a decrease in abundance of the pathogens, so Escherichia coli and Clostridium perfringens, and then increase in abundance of more beneficial bacteria like Blautia or Clostridium hiranonis. And even though these bacteria now, they renamed her, so it has this name Clostridium. It is really beneficial. It is also something that we evaluate inside the dysbiosis index. And it's known for quite a nice role that it has, and that is to convert primary bile acid to secondary bile acid. And those secondary bile acids we now know are really beneficial and really important. And we, of course, know that primary bile acids would be a bit of a problem if they are not converted and are present in the large intestine. They would cause a lot of issues with gastrointestinal upset. So yeah, here in this picture, you can see how the environment in the gut would change with this dietary management alone in those dogs that would respond to diet. So that the pathogenic bacteria would decrease. So those are the brown things, and that secondary bile acid producers or those bacteria that would convert those bile acids would increase in number, and also we would see increase in secondary bile acids, and those would be quite important. Now they are quite a popular subject in research in terms that they are known to be important in immunoregulation and also as a signaling molecule. So let's go back to the diets. Something that we would like to have in a diet that we are using for elimination protocol would be to have a few characteristics, and I'm going to now lay it out. So normally we would like to have a high digestibility diet. Poor digestibility would be problematic for gut, and it would cause more issues because it would lead to fermentation of maybe protein or other nutrients that are not supposed to be fermented. It is going to be disrupting the homeostasis in general. And then when it comes to level of fat, sometimes we don't mind a medium level of fat, especially if the problem is more in large intestine region. But if we have gastritis or if we have issues with small intestine, we would prefer a diet with low fat. And also if we have presentation of pancreatitis, sometimes it comes alongside the chronic enteropathy. Then oftentimes we prefer to have a novel protein in the diet just to avoid any intolerance or allergy, or the protein can be also hydrolyzed. And then when it comes to fiber, we also want to individualize that in terms that high fiber diet would be more beneficial in colitis, for example, and low fiber diet with low residue would be more beneficial when there is problems in small intestine and stomach. We want our diet to be quite nice in palatability so that the dog would eat it readily, of course. And in regards to protein, we also want to have different things in different scenarios. So for example, we don't mind a high protein diet in situations like protein losing enteropathy, but it would if it's too high, it could cause problems in case of, for example, complication with pancreatitis. So on the market, of course, we have a lot of diets. And of course, also, we are going to discuss that in detail later. But you will often see a grouping of diets being gastrointestinal. That would automatically mean that this diet is easily digestible and is formulated to support the gut health. But those gastrointestinal diets can be variable in its fat composition, so you have to check that, and also in fiber level. Sometimes they can be also novel protein, but not necessarily. Sometimes they are formulated with chicken, so that wouldn't be novel protein. Then we have novel protein diets. Oftentimes they are formulated to be more gastrointestinal, but not necessarily, so also something to keep in mind. And then we have the group of hydrolyzed protein diets that would use just the hydrolyzed proteins to serve as a protein source in those diets. And then we have the final modality that we sometimes would use, and that is novel protein homemade diet, but something that is super important, that it is just going to work if it's well balanced and if it's complete and adjusted for the pathology. And normally this could be achieved if you are working with a nutritionist, especially the one that is boarded by European College of Veterinary and Comparative Nutrition, or a resident also normally would be able to formalize such a feeding plan. Not an option that is always available for everybody in the world, but yeah, this is quite rare where we are going to use this modality. So can one diet achieve all we want? Normally, yeah, you see that that is not the case, and you have to select your diet based on the individualized approach that you take for your patient. So let's explain a bit about novel protein gastrointestinal diets. So those diets would be would have a protein that the dog hasn't come into contact in their life, but that would mean different things for different patients. In a sense that, for example, if a dog hasn't been eating anything with, for example, rabbit, that would mean that that is a novel protein for it. But if it has been eating some protein or some diet that contains that protein, it's basically not. So you have to do your anamnesis. And then when it comes to how they are formulated in regards to fiber or fat, they can be various levels. So you have to kind of check the label and see what you want to achieve with your feeding plan. But something that it's always quite consistent, that they are quite palatable, so dogs would quite readily like to eat them. And if they are gastrointestinal, it would mean that they are easily digestible. Something that we sometimes would prefer in those diets, and it's a good thing, especially in protein-losing enteropathy, or if the dog has lost a lot of weight due to the problem being on the small intestine level, we would like to have a bit more protein in the diet. And normally those gastrointestinal diets would have a higher level of proteins compared to hydrolyzed protein diets. And you would have a bigger selection on the market. So normally when it comes to manufacture, they should or are obliged to guarantee those characteristics with their quality of production process. That it's not really easy, because if they want to achieve this diet that is without any cross-contamination, they should adapt their process of production containing especially special cleaning protocols. And normally what is done is that those diets would be those diets would be prepared or extruded first and produced first, and then other diets that are not novel diets would come after, just to avoid the cross-contamination. So it is something that is quite important to do. They would also do the palatability and digestibility trials when they are referring to their diets as a veterinary diet. And then when it comes to hydrolyzed protein diets, those would be referred to hypoallergenic in a sense that if they are formulated well, and if the manufacturer has tested all the points, only in that diet we would have oligopeptides that are lower than the size of 2 to 3 kilodaltons, and that is not easily achieved. And the aim of this hydrolyzation of the protein, or basically So what they are doing is that they are splitting the protein into small oligopeptides, and those oligopeptides are small enough to not be recognized by immune system as allergens. And that is the kind of the backbone of this approach. Oftentimes, the manufacturer would add the carbohydrates in a form of starch, or sometimes it's going to be a whole carbohydrate like rice. And they can also be formulated with different levels of fiber and fat. Oftentimes, we see more higher fat content in those diets, but sometimes, manufacturer can formulate also a low-fat diet to be also hydrolyzed protein. They are easily digestible, but oftentimes we see problems in palatability. So this is something to keep in mind if you have a picky eater. This is not something that they would necessarily eat, to maybe then try to find your solution in this novel gastrointestinal or even novel homemade diet. And oftentimes the protein level is on the lower end, so just be careful of that when using those type of diets. Here, the manufacturer has much more job to do. It's also the same approach as with novel gastrointestinal diets, but here they have to normally test also with PCR the presence of different proteins in the formulation, and they also have to test for oligopeptide size, so that everything is below that size. So if something is bigger, then they have a problem. They should do palatability and digestibility trials, and that is basically it. And then this group that would follow, that I just wanted to mention what is the big problem with antibiotic responsive enteropathies and why this modality is being criticized that much and now being replaced with other things, is that antibiotics would cause dysbiosis. And I just wanted to show you this paper that really kind of pictures that quite nicely. So it is a study done by Pila and Jan Zukudolski. So normally they are quite active in the research in this area, and also have proven a lot of things that we are now using. And one of those would be this gut dysbiosis. So in this study, they did a study on healthy dogs, and they used metronidazole for 14 days in two groups. One group received just the metronidazole, and other group received metronidazole and hypoallergenic diet. And then there was also control. So what they found, and it's quite obvious in this graph, so that in day 0, both groups that received metronidazole, before they received it, of course, they tested the dysbiosis index, and it was normal. So normally the lower the number, the better. And there is a cutoff at dysbiosis index 2. So everything higher than that would be considered that there is a dysbiosis. So after 7 days of metronidazole, there is a marked dysbiosis in almost all of the dogs. Then at day 14 is the same story. And then when they stop the metronidazole therapy, at day 28, we see scattering of the dogs. So some returned quite quickly back to normal biosis. So this biosis index was fine. And some stayed in this red, so to speak. So we see quite a lot of dysbiosis there. And then what is really remarkable and shows how, the use of antibiotics when they need to be used, we would see some side effects from them. So that at day 42, we still see the same effect. So normally later on, a lot of dogs in those groups would normalize, but it would take time. So what we can do before immunosuppressants, So we can use probiotics, we can use fibers, and we can do fecal transplantation. So I'm going to quickly discuss those things. And as I said before, so with food responsive enteropathies and those modalities that are not that invasive, sometimes we would use them alongside each other, and we are not going to wait completely that the elimination trial ends and then introduce, especially with probiotics, if you see that that dog would benefit from them. So let's start with fiber. It is a big topic, but I'm going to shorten it super short. So normally in gastrointestinal diets and hydrolyzed protein diets that we use in elimination diet protocol, they would be included in quite various rates. So you need to check the label. Some are really low in fiber, some are medium, some would be much more higher. But when you need them and your diet fits well for all the points, but just not for the fiber, you can add it on top. This is not ideal, but it can be done and it works. So when it comes to soluble fiber, we would use it quite a lot in those patients with chronic enteropathy, and that would be normally psyllium. It would lead to increased viscosity. It has the ability to retain water, and it would slow down the motility of gastrointestinal system, and then it would give more time to the gut to absorb all the nutrients and water. And it would lead to oftentimes normalization of the stool. Something that is really important is to soak it before administration, because it would bind the water anywhere where it is. So it's good to do it, not good, but you have to do it before. If you don't do it before, so if the owner just gives a milled psyllium husk or psyllium husk in the diet, it is going to absorb water in the gut, and then we sometimes see even worsening of the clinical signs based on that. So it's important to soak it beforehand, and normally the rule of thumb is to soak it in 10 times more the volume of water than the volume of psyllium husks. Then you can use fermentable fiber, but keep it moderate, because too high fermentation is also not good. So here we have pectin or inulin as a good examples, and they would serve as a substrate for fermentation in colon, especially to produce those short-chain fatty acids. And then we have insoluble fibers like cellulose. Cellulose we would use more when we have issues with too dry stools, with some coprostasis. That is rarely the problem with our patients, but sometimes it happens if the diet is just really good for them. They can even end up with too dry stool and infrequent stool, and then you can add cellulose moderately, of course. And what is the influence of fibers? So what I said, generally we are providing substrates for the beneficial microbiota. And then if they are more abundant, they would bind to the enterocytes, that they would protect the gut barrier, and they would also serve as producers of those beneficial nutrients like short-chain fatty acids. And then with probiotics, we have a lot of them on market, not a lot of time to go over that subject, but I wanted to just say a few things about maybe the one that is quite frequent in use in chronic enteropathies. But now we see more research around probiotics and maybe more species-appropriate probiotics that are going to be quite helpful maybe later when we have them on the market. So something that is proven in this study, they used a multi-strain probiotic known with the name of BSL-3, or sometimes it is called Vivomix or some other commercial names. So it is quite heavily concentrated. They use really a high dosage. Normally, I wouldn't go that high with my patients, but they used it, let's say, in this 112 billion per 10 kilo. for 60 days, so 2 months, and they proven that there was a normalization in dysbiosis in a long-term therapy, and really shift when it comes to immune response. And they also checked the histological findings, and it was quite improvement there. In other groups, they used metronidazole and prednisone. So we can speculate that also metronidazole probably made the things worse for the other group. But yeah, generally they have proven really nicely that this probiotic would be a good option for our patients. And fecal transplantation is also something that is coming on a big door to our veterinary practices. But yeah, it is something that is probably going to be more practical to do in bigger centers where they have the staff and the equipment to do it properly. But generally, we see quite a nice results already. There is still a way to go with research to kind of see the exact protocol and stuff like that. But there is one research that I wanted to show you that is quite nice, and is retrospective case series where they looked at 41 dogs that received FMT. And it's by Linda Torrenson and again Jan Sukudolski, and they have managed to show that even in non-responsive chronic enteropathies, they saw a marked improvement in a quite large number of dogs. So it was more than 50% of those dogs that were considered to be non-responders. They responded so they responded to this FMT therapy, and they improved. So this is also something to have in mind. And now for our case that we are going to look at. This is Bonnie. He's 2 years of age, Boston Terrier, male, 3 out of 9 of body condition score. Muscle condition score is okay, but on the verge of mild wasting. And then the current body weight is 10.2, and I have to, and then ideal body weight would be 11.5 kilograms when recalculated on a body condition score of 4 of 9. And then, Bonnie has been admitted due to frequent gastrointestinal distress. And in anamnesis, it is a big one. So normally he has intermittent digestive problems since 12 months of age, so since 1 year ago. And then he had 3 times Giardia in his life. It was treated with Panacur and metronidazole with repeated therapy. Now he's okay with that. In the last 6 months, there are more frequent intermittent symptoms of gastrointestinal distress. Fecal score at this moment is 4 to 7, and then often the owner sees mucus, and sometimes once it was blood. The frequency is 4 to 5 times per day on a good day, and then vomiting also sometimes would happen 2 to 3 times per week. He has been losing weight for the last 2 months, and owner thinks that it is due to the diet that currently the dog is eating, because he's not liking it that much. And then the dog was given 2 times antibiotic therapy, so 2 months ago and 6 months ago, and then diarrhea would normalize, but then soon returned. And then, when it comes to nutritional anamnesis of this dog, so Bonnie, as I mentioned, doesn't like really the current diet. Owner selected the potato rabbit kibbles, as is said on the label to be like hypoallergenic, grain-free diet. And then because the dog is not eating, he adds additional chicken. And then Bonnie also eats various treats. And diet before was grain-free chicken and grain-free beef diet and various treats. So we can see from this anamnesis, there is a lot of contact with various protein, especially chicken and grain, and now also a rabbit, but we can maybe assume that here the chicken would be more problematic that is added to the diet. But also with potato, sometimes with these patients, they are not tolerating it that well. It can also, those diets that are grain-free sometimes can have a bit higher fiber levels, and for patients that are a bit more sensitive, for them it doesn't suit that well. So we can also look at those diets critically at this point. And then when it comes to weight loss, for example, that we see here. And then with the screening, everything was basically fine. So there was quite a good conclusion that this is working diagnosis of chronic enteropathy, and the goal would be to create a feeding plan that would correct a poor body condition score and diarrhea. And here I wanted to show you this graph that is quite a nice one from Tolbert from 2022. That is showing you what should be your way of deciding based on the clinical symptoms with what diet you should proceed. So I wanted to kind of highlight what we have as a problem with our patients. So it's weight loss, then change in appetite, but we can say that this is probably due to the fact that he doesn't really like the diet that he's eating. Then we have mucus in stools, we have higher frequency. So you see the mix of small intestine signs and large intestine signs in this patient. We see also a bit of delayed motility because the patient is vomiting. Not super frequent, but it is also not a small amount, 2 to 3 times per week. So what to select here? So something that should be prioritized just to kind of have a stabilization, I would say to go for small intestine signs. And then later, something that we would miss in our diet would be fiber. To also normalize the large intestine signs, we can add later on. So the diet that we can select here would be highly digestible, low residue, low fat diet, and to evaluate after 2 weeks. Something that is also emphasized in this graph, that after this type of novel gastrointestinal diet, if that didn't give you a good response, you can go to hydrolyzed protein diet. And if that didn't work, then maybe you could try a diet that is homemade, quite with low fat, if that is needed, or yeah, those would be basically the 3 options that are reasonably to go through in this elimination diet phase. And then with Calibra, we have quite a few options that we can choose from when it comes to novel protein gastrointestinal diets. So they have quite a nice selection of 2 options of gastrointestinal diet that is also low fat with novel protein. The protein is normally coming from fish, and we see here in the can, it's also lamb. And the source of carbohydrate is rice. That is good because rice is really easily digestible, and we wouldn't expect any problems with digestibility there. And there is also an option with gastrointestinal diet. There is also a novel protein one, but with a bit higher level of fat. So it's not high at any means, but we would consider it medium level. And for this patient, we decided to go with that is gastrointestinal novel protein diet, but in this canned form, and I will explain why. The reason for this selection is basically the palatability of the diet, and normally when the dog would feel nauseous, he would be even more reluctant to eat the diet that we are offering. So in those cases, it is reasonable to start with the just canned diet as only thing to give, and then later we can add some maybe kibbles that are from the same that has same characteristics as this canned diet. So to look at this diet, as I said, it has quite a low level of fat. When you see the number of a can on a can, you should recalculate it, as I explained if you watch the webinar related to pancreatitis. So this recalculated on the dry matter basis, it would be around 8.5 to 9% of fat. That is considerably quite low. And we have quite a nice level of protein that is on the higher end. So we can then proceed to calculate the MER. Here, I wanted to include that because there's sometimes with those patients where we want to follow up their weight gain, it is a good thing to calculate by yourself the energy requirements, and then you can increase them and have a understanding if that dog is gaining weight, or if it's not, is it the problem of the energy intake? So here I show you the formula for a dog that is like averagely active, and then the formula goes ideal body weight on a power of 0.75 times this factor that is normally used for average activity adult dog. And when we calculate that, we would get that this dog needs 687 kilocalories per day. And if we calculate the energy density of this diet, we would get this amount of grams, so around 947. That would be around maybe 2 cans and 1/3 per day. That is, quite a lot, but for this time point, it is a reasonable thing to do because the dog is underweight. And it also has issues with palatability. The number of meals, normally we would like to go a bit higher, so around 4 minimum. If owner wishes to go even to 5 meals per day, that is also encouraged. And in case of no weight has been gained in next 14 days, we would increase the amount of energy by 10%. And we would discourage the owner to give treats, or we would forbid him to give treats because they would cause a lot of issues. Maybe later we can find some hypoallergenic treats or use kibble from the same modality of the diet as treats. So when it comes to follow-up of this dog, we saw improvement after 14 days. So there was improvement of fecal score, but also mucus was present. Even though there was improvement, still some symptoms were still persistent. Frequency of defecation also reduced to 3 times per day. That it's not ideal. We would like maybe to go to 2 per day, but it's better than it was before. Owner reported no vomiting, and it's a good thing that the dog is gaining weight and really likes to food. So something that we can still change, because those clinical signs would imply what we doubted at the beginning when we selected the diet, that probably we would have some issues with this large bowel diarrhea that is not here, we wouldn't call it like that, but there are symptoms related to a large bowel, like mucus and a bit more frequent defecation. And we can try to correct that with a few simple modalities, like to add probiotic. I added this multi-strain probiotic in the dosage of 5 billion per kilogram of body weight, and also fiber. Normally, we would go with psyllium at the beginning and then see how it goes at a dose of 0.3 grams per body weight. Something to keep in mind, you should always, when you're introducing new things, you should introduce them separately, just to have better to evaluate better if something is working and how good is it working, or if it's not working. So normally maybe we'd go for first for the probiotic for a few days, and then if everything is fine, you can introduce psyllium. Psyllium should be always introduced slowly by thirds. So the first few days you can give 1/3 of this amount, and then later proceed to increase. And then also something that is super important is to soak it beforehand. And yeah, this would be the complete feeding plan for Bonnie. We are still evaluating, but it looks good so far. So we hope that Bonnie would be in this group of food responsive chronic enteropathy, and then we should that we are going to see long-term stabilization of this patient.